there's a different level of mobility and stiffness. It's a blend. So that's the skill. But I will say, even with the great athletes, if you were to ask me what's the single most common variable as to why they're coming to see you, I would say an underperforming core. And what I mean by that is there was an incident where the tuning between mobility and stiffness was inappropriate. But if you get that right, you can go to tremendous levels of demand on your back.
If we want to talk about evidence-based practice in the spine, it's impossible not to include Professor Stuart McGill in that conversation. Professor McGill was a distinguished Professor Emeritus at the University of Waterloo in Canada, where he spent 30 years running one of the most influential spine biomechanics laboratories in the world, investigating the causal mechanisms of back pain, how to rehabilitate people with persistent back pain, and how to enhance both resilience and performance. His field-shaping research, including over 245 peer-reviewed papers, is respected internationally across medicine, physiotherapy, and sports science. It has transformed how we look at back pain and how back pain is understood worldwide, and it continues to shape best practice in spine health today. Today, Professor McGill continues his work as Chief Scientific Officer at BackFit Pro, where he regularly consults on some of the most difficult back pain cases. His advice is sought at the highest level by governments, corporations, medical organisations, legal experts, and elite athletes and teams. What makes Professor McGill's contribution even more significant is how he has combined scientific rigour with practical application. His book, Back Mechanic, has become a widely used resource for people dealing with back pain, translating complex science into clear, practical strategies the public can apply. It's an honour to welcome Professor Stuart McGill.
Good morning, Brad. Good morning, I guess Canadian time. It's actually afternoon for you in the UK.
It is, yes, and it's we're in the middle of a heat wave, so we're struggling with the heat over here a little bit. But nice to see you this morning. So I thought a good place to start. So having gone through some periods of rehabilitation myself, both from illness and from injury, it's given me some empathy for my patients and seeing some of the journeys that they have to go through. So I thought if we start with an injury I had to my back, maybe that can lead us on to perhaps talking about some other things like anatomy, etc. So my particular injury was occurred back in 2012. And I've been racking my brains because I thought the more information I can give you about how it happened, the better. So I've been through a period where I had periods of inactivity, so lots of sitting. So I'd been studying, I was doing my master's degree at the time. So lots of times of sitting, traveling in the car, and then on top of that, I would then have periods of training. So I'd have periods of inactivity, then train hard, then inactive again, and then training hard. And then the actual mechanism, I remember the moment it happened, I leant forward, so I was bent forward and slightly to the side. I pulled my nephew's chair back from the television because he was sat too close to the telly, and I felt this really excruciating pain. I then had a period where could do nothing. So I got myself into a comfortable position in bed, took lots of painkillers and literally didn't move. So from that period, could we talk maybe around kind of things that might have happened in terms of anatomically what had happened and kind of how we start to unpick that?
I was doing a little pattern recognition exercise listening to that story, and I will lay a bet that, well, what you just described was a dynamic disc bulge. Uh, and if you told me where the pain went, I could probably converge on which disc it was. Did the pain go down your leg?
Yeah, so I had pain, and it was more the fact I had loss of function of left foot. So right down into my little toe and second toe in on my left foot, and I was unable to come up onto my toes on that foot.
So
So I lost.
you had a left-sided dynamic disc bulge at L4, L5. How close am I?
Yeah, almost spot on. So I had an MRI,
Yeah.
and they confirmed it was L5S1 disc bulge, and yeah, it was
Ah,
causing the symptoms down the left leg.
okay. Usually the fifth root of L5 goes to the big toe. but there is mechanical crosstalk. The nerves act as ropes. So if you pull one section of the rope, it also pulls other nerve roots as they're mechanically connected. But nonetheless, if we did a thorough investigation of you with an assessment, etc., I'm quite confident we would have converged with a bit more specificity. So, you're looking for a recommendation of what you should do, or a recommendation on how we would converge on the full process of understanding a bit more.
Yeah, so in clinic, I've seen a lot of people that come in with potentially similar symptoms to those, sometimes presenting slightly differently, but they are hell bent on getting an MRI, and they feel like their only solution is that they're waiting for an MRI. They have to have an MRI, and we also get the other side of that, where people have had an MRI and they come to us saying that they have a disc bulge. And really kind of unpicking around that in terms of they're often fearful that they can't do anything. I was myself, and they are reliant on these scans. So, kind of, I wanted to know your thoughts on the need for a scan to start with, and then secondly, what we can do with those acute episodes.
All right, you asked me a few questions, but those two final ones. Let me start with the last question first. You've got acute back pain. What sh should you be doing? We have to start with a thorough assessment because back pain is only a symptom with literally 100 or more different pathways to get to that pain. So if we change the conversation away from back pain and said leg pain, I've got this acute leg pain, you wouldn't know where to start in terms of how to wind it down, how to make it more resilient in the future. You would have to do a very thorough assessment of your leg. And we do exactly the same thing with back pain and the full linkage. So, no doubt, there would have been some aspects of biology and an anatomy that you've inherited that feed into this pattern. You will have been exposed to some physical stressors, and you identified a sitting for a long period of time stressor, which some people think that's benign, but it isn't. There's a cumulative load that is seen by the spine, but you also trained hard in periods. Those two don't go together because what you're trying to do with exposure is to adapt the anatomy and your body to become resilient. So you confuse the signals in a biological sense. And then I would consider both internal and external mechanics. The external mechanics is the load placed on your body, maybe in your hands or through your legs if you were in the gym doing things in the intense training part. But the internal mechanics are really where you need to go to understand the mechanism of injury because if you change posture and you sit slouched, if you sit upright, the loads distributed internally are mostly muscle. You're in a neutral range. But if you slouch, they shift from muscle onto the disc, some of the ligaments, etc. So we have to understand both the internal and external mechanics there. Anyway, all of this is assessed, and we would come up with a strategy for A, to wind down your pain. So you had a disc bulge, it's episodic, it comes and goes, which indicates to us uh, it's dynamic. I happen to have a few biological models here, Brad. If you were to look at this disc here, and you'll see a red mark right at the back, posterior lateral on the right in this particular case. And that disc bulge will change as a function of your posture. So if you are going to the gym and training intensely without good form and you bend forward, That doesn't do much on its own, but if you bend forward and squeeze, do you see the collagen delaminating, opening up, and the disc bulge grows, pressing on the nerve root, which went down to your little toes? In this particular case. But let me give you the antidote now. Instead of bending forward and squeezing, if you just stay upright and bend forward through the hips, so follow a hip hinge, you'll see the whole disc now is squeezing down, but nothing is being forced out posteriorly. So if I had an orange seed between my finger and my thumb, and I directed the thrust line, as it's called, right down the middle of the seed, the seed is locked. It wouldn't go anywhere. But if I biased my thrust line off to one side, the orange seed would squirt out every time because of the bias and pressure. It's pure mechanics. So that describes how sitting would have caused most likely the disc bulge to grow a little bit and then to expose your spine to intense loading, probably not in an appropriate uh, work rest cycle to load your spine, encourage some adaptation, meaning that now you have to give some time off or time rest or deload after you've exercised, etc. So that's the first job. Get rid of the cause, allow your back to desensitize, and then build some resilience. We're going to build mental resilience first by showing you very specifically what the mechanism is and then the best strategy to mitigate that one to one. Well, that's very empowering for you as a client. For the first time now, you're very aware of what the mechanism is, and now you know how to reduce the uh, uh, causal pathway. You've mastered it. You are now empowered. So that's the mental side of the resilience. And then physically, we will, through exercises and movement strategies, you can reduce the disc bulge, as I just described. And no doubt you did, because you're asymptomatic now, and you're well on your way. So that's what you can do as a client, and being properly coached. It's just as I said, so physically and mentally empowering. And you obviously found the way eventually.
Yeah, yeah, definitely. And I think kind of that
Oh, I didn't
you're
answer
gonna,
the MRI question, but I think I answered the two that you posed. Sorry.
yeah, and I think no, that's fine. And I think it's the way you said is by doing that, you were able to hit the nail on the head anyway, without the need for the scan.
Right. Um, I get asked quite often, well, what about the role of imaging, whether it's a CT for a suspected fracture or an MRI for a disc bulge or some inflammatory process that is visible on an MRI, etc. Most of the time, they're not needed. The person is responding based on the intervention the clinician provided to match what they showed in the assessment. But once in a while, the images are very, very important. It's when the pattern doesn't quite fit. Remember, I said we were doing pattern recognition. If the pattern doesn't fit, I'll give you an example. Let's say a client comes in and they say, I can sit and it doesn't cause my radiating symptom to my left little toe. But when I drive, it does. Well, what is it about driving that triggers the symptom that is different from sitting? And in this particular client that I'm thinking of, first of all, a little lesson in biology. Notice that the whole nerve tract migrates up and down. It's called nerve flossing. And if the nerves didn't floss, they would tear. As I bend forward, and I look down, me being the mock client here, it pulls the whole nerve tract cranially towards the head. If I extend my knee, it pulls the nerves the other way. Well, on this particular patient, when they sat, They would read a book, for example, and they didn't get the symptom. It wasn't till they extended the right knee to press on the accelerator pedal that the nerve drifted towards the feet. And then I knew because of it going to their little toe, I had to look at the fourth and the fifth root on the MRI. In other words, my assessment informed me of what I had to look for on the MRI. The radiologist had never seen the patient. They had no context for informing what they were looking at. They didn't know whether are they looking for a cancerous tumor or a disc bulge or whatever the case may be. But my assessment informed me to now go back and trace those nerve roots through on the MRI. And what we found was a little cyst. It's actually called a Tarloff cyst that was just outside of the foramen, and that was the pain mechanism. So there was no exercise that would have helped. In fact, flossing the nerve and doing normal nerve flossing exercises that many people would do inflamed the client. So do you see, I had to have the MRI to know it was the cyst, and then we made the appropriate referral to a surgeon who specializes in dealing with those cysts. And it's a very special surgical um, skill to have. Anyway, so there might be an example where the MRI unlocked that particular client's case. But to go back to the original statement, most of the time, a thorough assessment is sufficient.
Yeah, and that makes because what I would have done in clinic is maybe I'd have done something like a slump test, which would have reproduced. Then I might have then spent some time doing some flossing, and that patient then wouldn't have got better. So then it's not fitting the pattern of a normal recovery from that injury. Then you would refer.
Well, may I give something for your clinical audience hearing that?
Yes, of course.
Okay. Well, a slump test is well taught in physio school and clinical school because it is a reliable test. I don't do a slump test because it's a non-specific test. I was actually asked to write a guest editorial in Physical Medicine, Archives of Physical Medicine. It was a political piece calling for an end for journals to only publish repeatable and reliable tests. So there's an example. The slump test would not have shown you this mechanism at all. You had to play with the neurodynamics to simulate driving. So start with the patient upright, and then I would ask, do you have symptoms? Let's say the client says no. And then ask them, grab the seat pan and pull up as if they're holding two bags of shopping, say 7 or 8 kilo per bag. And then ask them, does that make the symptom change in any way? And let's say the answer is no. Okay, so now I've confirmed that in an upright position they can bear load. That's good. And then I might say, all right, now slouch. And they would say, oh, that doesn't cause pain. So I've just done the slump test and it didn't register. And then I would say, now add a little bit of cervical flexion. Full slump test. And they might say, no, no. Oh, well, maybe there's a tiny little signal going into my little toe. And then I might say, now extend your right knee. That could be part of the slump test. And they'll say, no, no, the signal's not there still. And then I say, now look up. Ah, there's my pain. In other words, no slump test would have shown that. I had to play jazz and really manipulate that slump test to turn it from a reliable test into a highly specific test. As the client lifted their head, the whole neural track then drifted into the Tarloff cyst, causing the pain. So that was the thing, that was the difference between doing a slump and sitting at the computer versus driving, which requires the head to come up. So do you see how we don't teach reliable tests? We play jazz with them and try and develop a clinical mastery of really understanding what the mechanisms are, and you can play with pulling on the nerve in different directions to really understand why that poor patient has failed every single clinical experience they've had.
Yeah, that's
It
brilliant.
was
And
just in
that's,
the clinical mastery of the assessment.
yeah, because someone like myself would have just gone by the textbook and this is the test to do. It's not that, and moved on to something else.
Right. That's why you would enjoy taking our summit course, as we call it,
Yeah,
which is uh, people spend 3 days with us here at BackFit Pro HQ, and we go over these very specific tests and the nuances of conducting them to really understand why that person has pain.
yeah, brilliant. So when someone's in that acute phase, is there anything as a clinician that you could do that's going to help that unwinding process? So you mentioned obviously you need to find what the trigger was. Is it simply a case of giving them an idea of what's triggering and then to avoid those? Is there anything that we could do, manual therapy, anything from some of the backgrounds that I've worked in? Sorry, I'm giving you millions of questions all at once, aren't I? From some of the settings I've worked in, for instance, in osteopathy clinics, people like to come in, get a few clicks, they feel a bit better, and off they go. Is there anything we can do in that acute phase that particularly is going to help to wind them down?
Well, the answer is yes, but I don't know what it is. So if the client goes to an osteopath whose billing code is to perform manipulations, you will get a manipulation. But if you go to a clinician who has a lot of different tools in their toolbox, you will get an assessment and then a tool that matches the particular pain pathway. So we have been one of the few groups to actually measure the response of manipulations. Most of the time, it is not a mechanical intervention, but a neurological one. So let's say a person has acute pain and they have a specific type of manipulation. Within 300 milliseconds, which is a short loop neurological reflex, the spasm and the pain can be greatly reduced. Ah, but how long does it last? Typically about 20 minutes. So when you measure what the mechanism of the manipulation was, it was a trigger of the stretch reflex. And the person experienced 20 minutes of analgesia. But now let me go to another model. So let me show you joint instability. So this joint is normal. It hasn't been damaged. It has normal stiffness and control. This one, L3, has normal stiffness and control, but L4 has been damaged and it's a bit lax. So now I'm just going to uh, perturb the spine, twist it a little bit, and you see the majority of the micro movements are occurring at L4, the one that's been damaged. So when the person lays on their side, that joint cocks off a little bit, as I'm showing you here, and they will get an ache, particularly right there. And then they go to the other side and the ache moves to a different location. So now, because the pain is migrating left side to right side, we know there's a little bit of joint instability. So you can manipulate that and get a 20-minute or whatever period of analgesia. But what was the mechanism? It's lost stiffness. The joint is already lax. Why would you manipulate that? Because tomorrow it's less stable or less resilient, and you have to keep repeating it over and over and over again. So it's a game that you won't win. So instead, uh, don't manipulate and try and restore some stiffness. After about a week, the person no longer feels the need to keep stimulating that stretch reflex. So there might be an argument against, but there are arguments for. Some people with back pain, and we were, I believe, the first group to measure this. This was proposed by Vladimir Janda, who is a Czechoslovakian neurologist, and he proposed the idea, based on clinical observation, that people, some people, many people, once they have a period of back pain, their gluteal muscles aren't fully engaged in the engram, in the muscle memory. In other words, the brain forgets that it's supposed to activate the gluteals to get up out of a chair. Instead, the person uses their back muscles and their hamstrings. Well, that's a problem from an internal mechanics point of view because it loads the hip joint and it loads the low back. So um, sometimes a manipulation can restore that pattern. Sometimes it can induce a spasm and make it worse. And I don't know how to predict. So there's another way to look at that. I can also go back into our laboratory studies, and sometimes we would implant an instrument inside the gel nucleus. So we would take a small bore, a fairly large bore needle, and we would pierce the outside of the annulus and implant whatever instrument we were putting inside the nucleus and pull the bore out. In other words, there was a little core hole in the side of the annulus. So we didn't tear the collagen fibers, we just made a hole and we delaminated them. So if I could demonstrate with my fingers here, there's the collagen fibers on one layer. Here's the collagen fibers running at the opposite angle on the next concentric layer because the architecture is sort of like an onion skin with many layers. Well, let me put a borehole through. So there's my thumb making the borehole, and you now see you have an open hole or communication, so the gel nucleus would leak out. Now watch, I'm going to do a torsional manipulation one way and the other way. I just closed the core hole. So there is yet another mechanical intervention. I tried to use all sorts of biocompatible glues and fibrins and whatnot to seal up the hole. And the most effective way I could seal the hole and stop the nucleus from leaking was to do a twist manipulation. So do you see how I, I'm not avoiding the answer. I'm trying to give the possibilities of maybe it is the precise wrong thing to do. Maybe it's a good thing to do. But having said all of that, if the person isn't cured after one or two manipulations, you must stop. And what I'm dead against is people who go in for their weekly manipulation for the rest of their lives. And I've been involved in some cases of people who have really massive joint instability, a lot of arthritis growing at that level. And they've been legal cases actually. And did the weekly manipulation cause the arthritis to grow just at that level over time? So there's no one who can say conclusively yes or no, but that's not my job as an expert witness. My job is to simply explain the mechanism to the judge and jury, and they use that information to make their decision. But anyway, do you see? Yeah,
Yeah, and
it's a huge question.
I love the way you say as well that it's like playing jazz, and there isn't just a, we're going to do this mobilization or we're going to do this test. It is so nuanced that you might have to just slightly change an angle somewhere or slightly change the way in which you administer that to get a result. So I find that amazing. There's a couple of questions, and I wanted to stick to my sec, but there's a couple of questions come up from those that I hope you don't mind me asking. So when you talk about that we can do in prone position, so laying on our front and moving, we can actually start to move the disc bulge. Is there a time limit for that? So if someone has had an acute disc bulge, an acute episode, and then we're looking at them, is there a time when you can no longer do that? Or is that something that remains a possibility quite far on into their pathology?
I would say as long as their symptoms are episodic, you have the ability to move it because the episodic pattern that they're showing you shows you that they are moving, if it is a disc bulge, they are moving the disc, moving in a way to cause the disc bulge to grow and then to shrink. So one of the best ways for certain categories of disc bulges is to simply go for a walk. So if the person says, you know what, sitting for an hour at my computer causes my back pain and going for a walk takes it away, they're just telling you that they are moving the disc bulge. So it's dynamic, and you could propel that with clinical techniques. And one you identified, have them prone lay. And I would begin by saying, breathe in and out, normal tide. Go to high tide, go to low tide, and I'm watching the curve in their low back. We know if we can restore a bit of lordosis, so there will be a subcategory where they're splinted into a little bit of flexion. The muscles have splinted on. And then the instruction might be, as you exhale, melt into the table. Just let your low back, and we're watching the lordosis with each breath increase. And then they might say, oh, I'm getting a little trigger at full exhalation. Okay, full extension is just a little bit too much. We might say, take your hands, palms up, and place them under your belt line. Now surrender into the table with each breath. And they'll say, oh, yeah, that took my pain away. Wonderful. And then after 2 or 3 days, they might be able to do it without their hands. Anyway, my point is, that is quite, and we measured this, that's quite an effective way to slowly reduce the disc bulge and prepare them for an exposure to a walking bout and really propel the therapy. Um, so again, we could play jazz. We could say to the clinician, good, while they're prone breathing, cradle around their ankles. And if you lift one leg and it feels heavy and you lift the other leg and it feels light, you know there is usually a neural resistance there. So that is another clue that there's something neural going on. But now pull in light traction. And they might say, oh, that causes a little sacroiliac pain. Great. Externally rotate the ankles. Oh, that makes it worse. Good. Internally play jazz. And they'll say, oh, you just took my pain away. Good. Then after a while, we'll do it. Do you see my hands doing a windshield wiper action? And then I'm watching their pelvis. And if I can get their pelvis to gently roll like this as I'm pulling in traction, that was the most effective way to reduce a open fissured posterior disc bulge that we ever measured in the laboratory and clinic over 40 years. So do you see how we just keep playing and romancing this? And then, of course, with the principles of spine hygiene, can they then create enough gristling of the joint to start adding some resilience so the disc bulge is less likely to go through the annulus and grow again. So we're trying to shrink the disc bulge and then make it permanent.
Okay. And you used the term there, spine hygiene, which if people haven't heard that term before, could you tell us a little bit more about that?
Yes, given the specific nature of different pain pathways, we give them movement hacks. So if a person has the posterior disc bulge, which I've already explained, and then they tie their shoe by sitting in a chair, if I can show this, slouching down and tying their shoe. There's no way they can tie their shoe without causing the disc bulge to grow. But if I was to stand and put my foot up on the chair. And then I'm scissoring down now. So I'm taking my hips to the target, which is my shoe. I don't bend forward. I take my hips down, push my knee forward. Do you see how I can tie my shoe now for free, sparing it of the known injury mechanism? So that is a movement hack and part of spine hygiene. How I brush my teeth, how I get on and off the toilet, in and out of the car. Uh, Perform daily life in a way that I've provided the client with movement hacks so now they don't get pain. I mean, I'll give you an example. In the UK, I was giving a lecture and there was one client or not audience member sitting off to the side. And I noticed that they were sitting slouched, just in the perfect position to cause a posterior disc bulge to grow. And by the way, if you look at every clinical textbook, clinical psychological textbook, what is the posture of depression? It is sitting slouched, knees together, with the hands in the lap and the head down. That is a indicator of clinical depression. So I'm just doing this pattern recognition, watching this fella sitting off to the side. I give my lecture, but in the break, he comes over and talks to me. And he says, Professor, I'm anyway, it turned out the poor man was suicidal because of his pain. He said, I used to be a police officer. I have lost my job. I can no longer do it. And I spoke to him a little bit more, and then I said, well, do me a favor. Would you walk your hands up the wall, suck up lots of air, and I want you to play cricket in the cricket posture. So big hands, put the kneecap or the patella between the thumb and the hands and grab hard. Now, play with the curve in your back. That's flexing like a camel. Now lift your tail. Now find a position. Can you find a position where the pain goes away? And he says, yep, there it is. I said, good. Push your toes down and be a leaning tower over your ankle. Now carry weight down your arms as much as you can. And now stand up, not by lifting with your back, by pulling your hips through. Use your hips instead of your back. And he looked at me and he said, my pain is gone. I said, good. Now sit down and I want you to roll up your hoodie and put it in your low back. Use the back of the chair and lean back and just be a peacock and relax. He came up to me at the end of the lecture. Remember, this is a big, tough police officer. He had tears in his eyes. He said, I have no back pain. No one had ever assessed him. They'd only given him manipulation, pills, exercises that were not appropriate. No one had assessed his back pain because they never recognized the patterns that I saw immediately. In any case, he then went from emotionally crying to real anger. They stole my career from me. Why did no one ever show me this? Anyway, these are such emotional stories, and I'm sure some of your listeners will be able to relate to them. But it's a roundabout way of answering your question, I guess.
No, that's and it is. I mean, having gone through that period of pain and then having these flare-ups, sporadic, when you are in a period where the back is hurting, it's draining. It just takes all of your not just energy but emotion, and it really can fry you.
Yeah. Brad, I'm going to say this because of your opening for this, your personal experience. It has made you into such a better clinician. I think of my father who wasn't a formally educated man, but he had such wonderful insights. Like he used to say, I think every judge should go to jail for a week, and then, they know. I also think every clinician should have an experience of their own, and it will so make them a better clinician in terms of motivation to continue their path to mastery because it changes people's lives. And it provides a level of empathy that pervades their life. They're not the ones that are there on social media criticizing everybody else. They're the ones that are trying to find solutions. And it really is self-motivating to change a person's life because they've been there.
Yeah, yeah, no, that's incredible. So something that while you were talking, I was thinking of when you were saying about your spine hygiene. So those hacks that you can introduce to someone, that then is the plan for then unwinding their pain. So you're then teaching them these, so they're not having those insults and causing their pain to flare up. Would that be then that's the plan to initially get them wound down?
Absolutely. It's a staged plan, but that's stage one. Yeah, if you can't
So
wind them down, uh, you can't go to stage two.
And then stage two would be adding then some stability to the spine. Would that be correct?
Usually, but not always. There are some people that have too much stability, shall we say. So stability and stiffness go together. So if I had going back to this model for an example, and we could say, well, all of those micro movements that are occurring is indicative of a joint that has lost stiffness. So relative to its neighbors, it is the unstable joint. Now, the root of stability comes from elasticity. So F equals kx. I don't want to get too heavily into biomechanics, but if you apply a force, the stiffness determines how much the joint moves. So if I apply a force to the first joint, it has sufficient stiffness, it doesn't move. But the next joint, when I apply a force, it's lost stiffness, so it has a big movement. Do you follow? So the joint is to add more stiffness, which is elasticity, to that joint. It arrests the micro movement and the pain is gone. Well, over the short term, you cannot cause the stiffness to return. Over the longer term, you can if you stop moving that single joint and it brings up to parity with its neighbors. But you would add stiffness in that particular case through a muscular co-contraction. So the most common effective one might be an abdominal brace. So if I was to coach that, I would have the client take their fingers, poke them not into the rectus abdominis, but laterally into the obliques. Poke your fingers in hard. Now push your fingers out. Okay, there is an abdominal brace. If you palpate the erector spinae, you will notice that they will come on too, because that created a flexor moment. You had to create an extensor moment to balance it off in terms of the internal mechanics. So now that you've created a stiffness, a more stable spine, and you've arrested the micro movements, so now you don't get the pain triggers. So remember the short stop squat or the cricket type of squat that we did? Do you see how now I can bend over, pick up something using my hips, and I'm stiffening out, shall we say, that micro movement and the pain trigger. Now I will get the client say, take your right hand and touch my right hand over there. And if they do this, oh, I just triggered my back pain. Good. Let me uh, inform you a little bit. Turn the hips. The rib cage and pelvis go together. Now reach across. They're not quite reaching. Push your hips back a little bit. Oh, good. Square up, pull your hips through, and there we go. So what I'm showing is martial arts 101. You are creating strength to apply to get a mechanical effect on an opponent to take advantage of their weakness. But what they don't realize is because of their movement patterns, they're allowing life to do jujitsu on them. And what we're showing them is how to be resilient to life. And that's a bit of spine hygiene and these movement hacks, etc. So does that give a little bit of a story to tell to answer the question, perhaps?
That's brilliant. And it even demonstrates exactly that position that I got in with my nephew that was, I think, was the trigger for mine. I'd put myself at a mechanical disadvantage, being rotated and leant forwards. And yeah, that goes in to what you said is then I've put myself in this bad position,
Right.
which if I would have done in a better way.
Yeah, it's so much fun. As you know, my real specialty is elite athletes, and I will take, we've got a number active right now in the UFC, which is the combat league that are you familiar with the UFC? Okay, so we have several clients there, and it's so much fun to, all right, I've been working with them for a year. I've been able to get in the octagon with them and have a little bit of a play, and I'm the old man, and they're not allowed to try harder than 2%. These these men and women these days are not what they used to be. They are absolutely at the highest level of skill and mastery. It's just incredible. But you know, to see them when pain corrupts their athleticism and their motor patterns, it's so incredible to see these beasts becoming so weak because of their pain. And the pain, as I said, corrupts their patterns and they lose their skill. But just to teach them a drop step, drop back. Okay, now spread your wings, drop back, play basketball, box someone out, and come back. Or forehand in tennis, drop step the other way. Backhand in tennis, but keep the rib cage and the pelvis together, just as we were doing before. Now, take a contact on the opponent's back of their head or shoulder or arm drag or whatever it's going to be, and drop step and pull, and then pull. Pull in. Do you see how you stay tight? And all of a sudden they're starting to flow into jujitsu now and their various takedowns. So it's so much fun for me to then watch them compete. I must say, I hate watching them compete because it's just a horrible thing to see them destruct their bodies. However, my job and my passion is to help them, not to judge what they do necessarily. My job is to help them move without pain. And it's a struggle for me sometimes, but I have to get past that dissonance. But anyway, to show them these skills and then watch them in the octagon do such perfection of the movements and spare their particular injury mechanism. That is a real kick, I must say. Or to go onto a pro tennis tour where the person was basically disabled a month ago, and within a month they've been able to change their serve or whatever it is, their hip patterns perhaps, and really uh, avoid the injury mechanism. And now they're just at peak world-class performance. It's a bit of a kick, I must say.
That's right. And while they're actually fighting, or in the tennis case they're playing, you're thinking, oh, all that work that I did to get you there, and you've got someone that's trying to wrench your arm off, and I'm doing all my good work.
I do have that thought, I must say. But you know, even if I don't know the athletes, I still it's hard for me to watch sometimes.
You start watching sport. I remember when I was first training, when I was first doing my bachelor's degree. You then start watching football matches, and you're watching how people are turning. You're thinking, "Oh, that was close." So yeah, you start to then kind of assess every movement. Or you're walking along the street and you see someone walking, you're thinking, "Oh, you're going to start to develop a problem with your knee if you walk like that." Yeah.
My wife, she knows what I do when I'm out in public. I can't help but see all the movement. And it's just so front and center. It's hard for me just to let my brain relax and not be observant in public.
Yeah, diagnosing everyone you see. So there was something there when you were talking about this mobility and stability, that kind of got me to think, is it possible to have both? So, from watching some of your work before, I've heard you talk about willowy spines and then they're stable. So the difference between kind of, for instance, a yoga master against a power lifter, and having those completely different body types. With the way things are with fitness trends at the moment, there's people that are trying to do everything. So you've got like your CrossFits where they're lifting heavy and they're jumping and they're running and they're doing everything. Can you actually have both, or do they oppose each other, the two?
All of the above. So it's very context specific. Um, First of all, a high performance CrossFit athlete has been almost touched by the hand of God. They've they've got a phenotype of a body where they can take high load, become tired, break form, and still be somewhat resilient. Now, having said that, I've also had some winners of CrossFit as clients. So they manage their pain a lot more than people may think. Um, uh, but that may or may not answer your question. Let me just go back for a minute and go over that idea of stiffness. So every biological tissue has a mass. It weighs so much. It also has stiffness, high or low. It's just a variable like mass. So um, we all have in every one of our tissues stiffness. F equals kx, k is stiffness. When you push something, how far does it move? If it doesn't move very far, it's stiffer. That's all it really means. So if I was to push you like this, okay, that's a certain athletic push. But if I was to load my finger, bam, and then snap you, that's a different level of athleticism. So I've now used elasticity. I've tuned the stiffness and I've unleashed that elastic recoil plus the muscle contraction to have a devastating athletic effect. So do you see, it's not having mobility versus stability and stiffness. They are a continuum. Now, uh, and none of it's bad. It's just it might be inappropriate for the desired effect. So if I'm going to lift 100 kilo, I need a lot of bracing in the muscles. I purse my lips, I control my breath. Because if I breathe out, relax, phew, I'll lose the lift. Or my spine will buckle. It doesn't have sufficient stiffness to carry that load. But right now, I'm sitting in a chair talking to you. I want to dance. We've measured Middle Eastern belly dancers. They have incredible mobility, but they don't have much strength. Not one of those women in our study could do a competent sit up. So it just goes to show you the more of a specific stiffness or mobility you have, generally speaking, unless you've been touched by the hand of God, you have to sacrifice the other. But I don't think that was your question. Your question was for average people. And of course, average people need a little bit of mobility. They need a little bit of stiffness and stability. The trick is, can you tune it? Those who are tuning it are the ones who don't have back pain. The ones who do have back pain aren't skilled enough to create sufficient stiffness, which is control. So if you were to design a race car suspension, what are the engineers tuning? They have a spring and they have a damper. They're tuning viscosity and stiffness. So that race car is the fastest and in most control going around a corner and over a bumpy undulating surface. So we must do this as we are running, walking, sitting. Sitting is a low demand. But picking up your child out of the crib at 2 in the morning requires a different level of mobility and stiffness. It's a blend. So that's the skill. But I will say, even with the great athletes, if you were to ask me what's the single most common variable as to why they're coming to see you, I would say an underperforming core. And what I mean by that is there was an incident where the tuning between mobility and stiffness was inappropriate. But if you get that right, you can go to tremendous levels of demand on your back. And
Yeah,
when you get
and
tired, you lose that ability. So what does CrossFit do? They make the athletes tired. There's a huge endurance component. So that's the key to surviving CrossFit. Don't break form. You know, when you go to the Olympics, there's someone coming to the fishing line, not the fishing line, the finishing line. What does the coach say? Don't break form. Keep good form. You know, it's in running, it's in cycling, it's in so many things. But when you get tired, your form breaks. And now you
I,
start messing up the beautiful blend of mobility and stability and control. The internal mechanics causes one element to become overloaded and it breaks.
Yeah, and I suppose that is, I mean, we might see that in someone's been sat in an office all afternoon and then they go to the gym in the evening and they're trying to break their deadlift record, and it's no wonder
Right.
that they're ending up with an injury.
Yeah, precisely. Yeah, one of the uh, quite detrimental patterns that people don't realize is you cannot undo 6 hours or 8 hours of sitting at a computer with a 1 hour uh, heavy training workout at night. You'd be far better to do short little breaks throughout the day and not be quite as intense at night in the gym. And most likely you will have less pain. And people will say, "Oh, well, that's so unfair. You know, I go to the gym and I lift heavy and they're wondering why they have pain."
Right, that's been amazing, and that's covered everything that I wanted to cover. So thank you so much. And the way you explained things, one of the videos that I saw, you explained about reducing tire pressure, and then the effect that basically that would have on the facet joints, and talked about it in terms of a tire. That was amazing, and that really helped me to visualize what was going on in those patients that you see with irritable facet joints, for instance.
Good. I'm glad that helped. But in any case, with your own career now, I wish you the best of luck and all the joy that comes from changing people's lives. So good for you.
Yeah, thank you so much.
My pleasure.